We're going to call up Dr. Hanau to give his talk, CPO crossing.
Hey, Venki, can you hear us?
Sonia?
You're never ready in your life ever,
George
and you're an
Adams?
hour early now.
Oh, that's good, because you know what? There was a trauma in Osborne, and so the next case, which we're going to do from the hospital, I may have to juggle a lot of things to get that other case going. But anyway, just pull the wire back, please. Okay, watch the screen. Okay, so let me present this case that we're doing, and I think it's a good segue to what you're discussing, because right now, everything is moving to the outpatient, as Dr. Dipple and everybody else has stated, even Dr. Jain. And I think all cardiovascular procedures are going to the outpatient, at least the majority of them. And of course, there is a controversy here as to what do you do in the outpatient, what is an OBL, should all ABLs be converted to AACs, should there be some regulation? And so there is a stage right now in this transition or this shift.
Doctor, are you talking to me?
Where my patient's talking to her. So anyway, there is this transition, and we have to be a little careful as to what we do and how we project ourselves without getting into too much trouble. But I sincerely feel that a lot of these procedures that we do in the hospital, in the cardiovascular space, can easily go to the outpatient with good oversight, good regulation, and good data. So let me present this case. She is, can you go on to the history, please? Oh, before I go there, this is Dr. Loda. Ankur is, unfortunately, an interventional cardiologist. But again, like I said, I've learned a lot of skills from interventional cardiologists and radiologists. And Sonia will know that I do everything that they do and much more. So this is a 77-year-old female who has severe peripheral arterial disease, still continues to smoke. She's had major peripheral vascular interventions. She's had an aortobifemoral bypass, a fem-fem bypass, and now she presents with right foot wounds and severe wrist pain. So that's what started on the top of the foot. And we were treating it conservatively, the wound's not healing, but it shows some granulation tissue. Then she started getting another wound on the tip of the toe. And then that's when all the wrist pain and toe pain and everything started, and we then felt that, yes, I think she warrants an intervention, at least to see if this will heal. Her ABIs were 0.48. We didn't do TCPO2s in the wounds, and we did do a CAT scan, a CTA. And if you look at that CTA, you will see that there is an aortobifemoral bypass. There is also a fem-fem bypass, which is occluded. So I think the fem-fem came first, and then the aortobifem. And you see the aortobifem, like we said, is a great operation. The patency rates are excellent. It's a great conduit to the outflow to the legs for further future interventions. And as you come down further, you'll see that big hood of the aortobifem. The proximal SFA is almost nearly occluded, and the diffuse disease of the SFA as you go down further, we're going to the adductor canal. Right there appear to be, at least on duplex, two tight areas in the proximal SFA and at the level of the adductor canal. And then the below-knee runoff with CTA, you can see the dye sort of dies off. But I think if you really look at that CTA, you'll see that there's a single vessel runoff. So now I'll give it to Dr. Loda as to how and why we chose radial access. Why do I do mainly left hand versus right hand? What are the catheters that you use? And where has radial to pedal reached at this stage of the game in peripheral interventions?
Yeah, thank you, Dr. Ramaiah, for kind words. But so in this case, I think radial access makes absolute sense. She has an aortobifem bypass, so going up and around from the other side of the groin is not possible. The other thing is she only has one vessel runoff on the peroneal artery, so going from pedal approach upwards is also a difficult one since it's the only vessel that is available. Luckily, we are at a point where we have catheters and atherectomies and balloons that can go as far as down the pedal loop and come back up. So we chose to do radial access. Her radial artery was around 2.3 millimeters. Previously, we had 6 French sheaths that are available, but now we have come down to a 5 French sheath, and we can even do radial arteries that are probably less than 2 millimeters very safely in this. So this was a 2.2 millimeter radial artery. We got the diagnostic angiograms, and after the diagnostic...
So all radials we did under duplex guidance. I mean, I'm old school, and we used to think that we could puncture any artery in the body just by feel. Yeah. But I'm telling you, use of the duplex ultrasound even in the surgeon's hands, is excellent. So I do all access under ultrasound-guided access technique. So we punctured this with the radial kit, gave the cocktail, used a rim catheter to get up and, down into the descending thoracic aorta. And then we have this long 120 centimeters, really slick, sublime sheath. Not really sublime, but sublime is the name of this sheath. And we took this 120 sheath, all the way down to the groin area. And you can see on fluoro. Are you live on fluoro,
Yes,
Chris?
we are.
Okay, there. So we took it all the way down, and you can see that proximal SFA, the velocities there were like in the 700s, 600s, especially at that proximal SFA. So the other thing Dr. Lourdes said, why you chose radial, yes, you could probably puncture antegrade into that limb of that aortobipham, but again, you're dealing with a very short segment, to try to get through that lesion. So I think if you really look at it, I think this is the ideal case for a radial approach. I'm not the biggest fan of doing pedal access all the time or jumping straight to radial. I'm still, the groin up and over guy or antegrade guy. But I think all peripheral interventionalists, including the surgeon, should be able to try to give their patients every opportunity for the best possible results. And so we need to educate ourselves, train ourselves in how do you do radial. Okay, that's one. Yeah. Second, we chose left radial. I'm a bigger fan of left radial because I know this is a question I ask everybody whenever a radial topic comes up. Why do you use the right hand? Left is easier. Patients are mainly right-handed. So that choice, you have to be very careful. You don't want to destroy their right hand, whatever you get reflex sympathetic dystrophy or whatever it may be. Make sure you do an Allen test. Make sure you document with the ultrasound. Pick and choose your side. And then I prefer to use the left radial. So now that angiogram, let's play the angiogram. Let's do with the, yeah. So this was our angled catheter that we used all the way down to the groin. Next picture. And you saw the proximal portion. Let's go distal. Yeah, that's the proximal lesion. Then you have the SFA distally, not too bad, little disease here and there, nothing significant. And there was a lesion on ultrasound near the adductor canal that had very high 400 velocities or so. That may show up here. Right at the bottom of the screen, right where that collateral comes off, there is almost like a plaque or a dissection right at the adductor canal at the bone shadow. Then we went further down, just for the sake of completion, did a picture of the popliteal, is open, and then you'll see that right at the takeoff of the TPT trunk into the peroneal, the AT is occluded, the PT is occluded, the TPT trunk shows a lesion, and then the peroneal is the main artery that goes down to the foot. I think there's a better picture. So what we did was we put in a catheter all the way down into the popliteal and did a selective completion angiogram of the entire circulation to the foot. Can you show us the picture of the foot? That's the lesion in the TPT and the peroneal, and that is the circulation to her foot. So I think, we don't have to get gung-ho in trying to open all three vessels. I think we open the inflow, the adductor canal, and the TPT trunk areas, and then I think she'll do fairly well. I'm not a big fan of running into angiosomes right off the back and try to get into the DP and things like that, but I think you can always approach that if the wound's not healing or her symptoms get worse. Okay, so now we crossed this lesion. We got our 120 centimeters sublime sheath all the way to the groin. We then used a 014 wire, got all the way across these lesions into the peroneal. Then we exchanged that for a 470 centimeter long Viper wire. And now we've got a wire all the way down into the peroneal.
The laser.
And now the question is, how do you treat this? And I think just ballooning. So the discussion we need to have is, because there is such a bad name given to atherectomy, and it's not atherectomy that is the problem. I think it's the reimbursement issues that are a problem. Today, if they say that cutting balloon here or scoring balloon here or DCB is going to have the maximum reimbursement, physicians will automatically use it. And so it is not just the procedure that is coming into scrutiny, it is also the kind of reimbursement and what's the biggest bang for your buck. That's how you practice medicine. So we've selected, and then doing radial approach, a lot of these atherectomy catheters are not long enough. So I was one of the first, I think, about a week or two ago, where we used this long 225 centimeter 1.5 laser catheter that goes all the way down to as low as you can go. So that's what we're going to do. We're going to do this 225 1.5 laser catheter. We're going to do laser atherectomy of the proximal SFA, laser atherectomy of the adductor canal area. Little hesitant as to rush in with the laser for that TPT lesion, or we may just balloon it. After that, we'll shoot an angiogram, and so let's start the laser now. So, is it on? Yes. I think we'll go straight to 60 fluents. You got wired, Justin? Good. Okay, hit it. Is it on? 1, 2, not yet.
It's on.
Okay, let's go. So you can see this laser catheter is right there. See that? I hope you can see it. And now we are entering into the proximal SFA. And the key to any atherectomy is to go slow, let the laser do the work, which I don't follow even in my golf game. But go as slow as possible because you don't want to snowplow this lesion. And sometimes, this is a fairly short lesion, so I will make multiple passes here and see if you can at least soften the plaque. Yes,
Venki,
you could use other kinds of atherectomy here too. Go ahead.
Venki, what kind of laser is this?
Sonia?
We can barely see it.
There it is. I have glasses on.
So,
I have
Mr.
glasses
Woolley, can
on.
you show the other screen?
Show the other screen. See, I'm on a road map, so you can actually clearly see the laser if you see both screens. I generally do a lot of work,
Yeah.
here, that's the laser catheter. You can see it very clearly. But under road map, maybe you're not getting a really good
Oh, yeah,
picture.
yeah,
Okay, just go live again on road map now. So
See
we'll
invisible laser.
continuously follow this up a little more, make a few more passes, and then we will go down further into the, I don't think we need to do anything more here. Okay, let's hold the wire, please. Off laser.
Yeah.
And now we're going to go all the way down into the popliteal area, the adductor canal area. The rest of it was all fine. Okay.
What kind of feedback do you get? How do you know you're done?
Well, sometimes you can hear the tone of the laser, like even in atherectomy, when you do directional atherectomy, you see the motor, it gets muffled. See, here I can hear,
Yeah.
I mean, the acoustics are not the best over here, but you can actually hear that laser catheter when it's in a good lumen, and then you'll suddenly realize that the tone's gone. So we're going all the way down here. And that's the area where we saw that correlating with the duplex ultrasound too. Okay, sweetie. Sometimes they do feel it,
Yeah.
Press this.
The wire.
I mean, there are two lasers right now. I mean, I think Dr. Dipple can speak on the excimer and the other laser that's by Philips, and we can talk about this laser by angiodynamics. And I don't know whether you can compare the two, but I think I worked with both of them. But this is the only laser catheter that is long enough to reach all the way down to the distal below-knee vessels too. I'm not going to touch the TPT peroneum.
We'll take it off.
Yeah, let's take this laser off. Any questions in the meantime?
Yep, I have a question, Venki. Why did you choose laser versus orbital atherectomy or any other atherectomy devices? And the second point I would like to make is that before doing the radial approach, it's important to do the Allen test because
Yes, yeah.
sometimes that
I
gets
did
forgotten.
Allen test with clinical, yeah. Well, no question. Before you touch this radial, you definitely need to evaluate the circulation to the hand, and that is the Allen test. I also do ultrasound, duplex ultrasound. This lady, for some reason, was in the clinic for a while, and while doing an ultrasound of her leg, I even looked at her radial because I thought it was really, really tiny and really small. Okay, wire, yeah.
Lost the wire.
It's okay. It's okay. Push your wire in.
Push the wire in.
And this is the thing with long laser catheters, because you literally need to go into the other room to actually, put it straight. Yeah, that's okay. We can cross it back again with the catheter. So this is what will happen when you have these long laser catheters. There should be another, and that is why I say all of these should be rapid exchange.
Yeah.
If you want to do radial, I think every balloon, every atherectomy device, all of these should be rapid exchange, because these wires are literally going to camelback and. So let's pull it. I got it. Okay, so that was the first question, was the radial. The second was, why did we choose laser?
Very sticky.
Because this is one of the latest sort of products on the market that they have gone over to increase the length of the laser catheter. I did a fair amount of CSI.
So do me a favor.
And I like CSI for short
now
focal calcific lesions. I do not like CSI as much for long segment CTOs of the SFA or
It's
even,
fine. Give me a
but I
give me
think
his regular
CSI has a
wire.
really good role
Give me the
in
regalia.
below knee calcific disease,
to
like in the
the
diabetic and the
access
renal
now.
failure patients. You could have done atherectomy with the Silverhawk or the Turbohawk here too, because the proximal one you probably could reach. And plus, it's a monorail system, so yes. But I think laser is easier to use. Huh?
At the distal. We got it. You keep talking.
Yeah, so that's the reason why, I chose the laser. And I think I do a fair amount of laser now in the outpatients. It's easy to use. The luminal gain is not too bad. But when it's severely calcific, then, of course, then I think you may go up to CSI and then further that to directional atherectomy. The next thing is yeah. So the other thing that we are looking into, one is the outpatient space. The second is obviously all the new technology and the lengths of catheters, wires, imaging systems, and things like that. But also, another thing about meetings is the audio-visual transmissions. And as you all know, the Avail systems, they recently went out of business. And so there are a lot of these new, just go to the groin now. Let go. So basically what happened here, and Dr. Loda can speak to it, is that the wire, like I said, is such a long wire that taking the laser out, you need to have some irrigation with the laser to make sure it doesn't get too sticky. And taking that laser out, we did lose, see how good I am? Follow that down. We did lose that wire, which is that, so I think we can take this wire out now. Yeah. And go live, please.
Why are you replacing that wire, Venki,
a
and what
loop. I
kind of
don't-
wire is it?
This is a regalia wire. This is just a regular 014
Just
wire.
get me the catheter, 018 catheter.
I think what happened is currently the current lasers are 220, 30 centimeters, but the only wire that can reliably deliver them will be a Viper wire. So we're, I hope the industry people are sitting there with their booths and we can come up with a 450 centimeter good torqueable 1:1 torqueable wire. What ends up happening is Viper wires are made out of steel and they're single, they're not having any coils around. So any amount of bend can make it difficult for an over-the-wire system. So as the systems will go towards an RX system, our dependency on these long wires will go down, and we can continue to do these cases regularly.
So we'll leave our wire over there, and we will go back to the groin, take an REO picture, and see the question that I ask everybody in the room when I do laser is, what did the laser do? Fantastic. So now the question for the panel and the moderators is, what else do you do here? Obviously, atherectomy is done. You've probably modified, softened the lesion. Almost looks like we may not have even touched it. So how would you treat this now? Simple balloon angioplasty, cutting balloon, scoring balloon, DCB. What else would you do here? Any options? Any questions?
I think DCB should be the option at this point.
Yeah, and Venki, this is George Adams. So two questions here. How often are you using intravascular imaging?
No.
Number one, and then number two is before
good idea.
before using a drug-coated balloon, I'd probably prep it a little better with a
Serenator, you can
non-compliant
give me
balloon.
that.
Yeah. So straight DCP, like we said, even when we did the trials with DCPs, we did a
Five
plain.
is okay.
Yeah, we did. How do four? It's non-compliant. So anyway, so we would do plain balloon angioplasty, like with a 4 millimeter, and then hit it with a 5 DCB. So I think we need to prep that lesion prior to hitting it with DCB. IVIS is a great option, George. In fact, I was remiss in not trying to hook up the IVIS. We do a fair amount of IVIS, and this will give you a lot of information about the calcium, intraluminal crossing, length of lesion, kind of lesion, and also good results. So IVIS is really good, and I think IVIS should be our absolute. We didn't hook up IVIS here, right? We can, but I don't know how much time we have because I need to go over there.
This is a Serenator.
Yeah, IVIS is monorail, so we should be able to. Okay. Yeah, but George, yes, I totally agree. IVIS is probably a very good option for these procedures. What I was saying was, so we are using, I mean, this could be because recently there's a large amount of emphasis apart from atherectomy.
He needs the wire.
Apart from atherectomy, to use a new sort of technology. You got it? This is the thing with wires, you know? You got it?
Hey, Vinky, it's Miguel. Good morning.
Beautiful.
Just as you're delivering that balloon.
So this is, the one I'm using is known as the Seronator. It's a sort of a cutting, scoring balloon. It comes in different sizes from below knee to the above knee segment. I think the largest diameter is a 6. So we'll hit this with a scoring balloon. There it comes, right here into the orifice. That's where the anastomosis and the hood of the bypass is. So this is like a scoring or a cutting balloon. It's a relatively compliant balloon, so sometimes you have to be careful. You have to take it up very slowly. Can you go live? So you take it up very slowly and see, it's a relatively compliant balloon, so I need to take some of the air off here too.
Vinky, are you able to hear us?
So basically, after treating this, maybe then you can use a DCB. But my approach towards using DCBs is sometimes do not use it as the very first line of treatment here. I'll do atherectomy, DCB. That used to be our standard treatment. But now with these sometimes long segment SFAs, I tend to do atherectomy and balloon, and if I get a good result, I tend to leave it. If they do come back, and which I know they will, then I tend to. So this sort of an algorithm of how to treat the SFAs is very, very important, and everybody has different choices into how they treat it. So some people, I had another patient with a long segment SFA stenosis occlusion right from the origin to the adductor canal. And the question is, would you do endovascular? Would you do a bypass? Which is your first option? So everybody has their own reasons on how they treat. And so you need to come up with your own plan, agenda, and what works for you also, in addition to also knowing
Vinky.
what is the durability of these procedures.
Vinky, are you
Yes.
able to see the panel?
Can we go? I cannot see the panel, unfortunately.
Okay,
From
some
here, I
of
can
the
tell
panel members
Yeah,
have
go ahead.
comments or questions.
Oh, yeah, go for it. That's the duty of the moderator. Okay, stop right there.
Hey,
Question.
Vinky, I don't know if the audio is a little bit low on your side, but I was just wondering, one of the things that we use a lot for this sort of decision making is intravascular ultrasound. And the codes are, the codes are there for outpatient office-based lab too. And this seems to be an interesting lesion because it could be potentially fibrotic. Next to that, anastomosis. It could be just progression of disease. And to your point as to what should we do next or what tools should we use, I think IVIS could be crucial to tailor the therapy. What's your thoughts, and do you use it or not?
It looks better. Looks much better. Yeah, I use IVIS actually, and in fact, we were in a rush because I was in the trauma that we didn't hook up IVIS. But if you want, I can hook up IVIS and Loda can continue. Good or bad, I really don't know. But let's go ahead and balloon the distal portion with just a regular balloon, where you have a. Go down further. Go AP and go down further. Now, why don't you give me like a 4 long balloon? Because there is, I'm going to go to that adductor canal lesion.
The wire is folded.
Yeah. Let's get the catheter here.
Give us a 150 crossing catheter, please.
We have one here.
It's 200.
Yeah, that's 200. Yeah.
Venky, you need a fellow to hold the
So when
wire.
you do radials, I think there's a lot of thinking going on because sometimes the wires may not be too long, the balloons are too long, balloons may be too short, so sheets, all of these things have to be taken into account. I think that lesion, and you're right, if you can hook up intravascular ultrasound, it'll also tell us whether we need to stent that lesion or what is the luminal, diameter of that with IVIS. Is there a dissection flap, and what is the flow like? So yes, IVIS is extremely important, especially in lesions of this kind.
Venky, Another question for you. Choosing between the atherectomy and the balloon, how did you make a choice using laser and then using a balloon?
Pull the wire in. One second.
Well, you do your atherectomy, and then, of course, most of the time, just atherectomy, if you get a good lumen, yeah, you leave it. And you do an IVUS, you do a completion angiogram in 2 views, and if you think you've got a good result, you can leave it. But a lot of times, atherectomy is not a totally definitive first-line treatment. It is always associated with further adjunctive treatment, whether it be balloon angioplasty, DCB, or even a stent in a balloon or a cutting balloon. So, you got it?
Yeah, you keep going, and then I can straighten up the tip after.
Yeah, I'm going to, yeah. So I think we're really, what I'm going to do is, I'm going to get this wire down all the way down into the distal adductor canal lesion or even into the peroneal lesion. Touch it up with the balloon, and then, okay, go ahead, Loda.
No, it's good.
I may have to change that wire. It's too floppy, flimsy.
Give me another wire, please.
Just get me a command or something.
Yeah, Venki, that's the problem when you let a cardiologist choose your wire.
Which wire is that?
He's using,
This one
I think
is a
it's
regalia
a
wire.
regalia. Choose a command DS with night no base,
Yeah,
and
it's
it
a
won't do
regalia.
that.
Follow it up. Yeah. See?
Let him.
Okay, follow that down. Yeah, sometimes you're right. I like the command wire. Let's talk about a few wires. I mean, I think my favorite wire is actually the command wire. Okay, let's go down. Why don't we first get a 3 balloon, 360, 380. We'll do the
take this
TPT
crossing,
and the
cut that
peroneal.
out.
Take it out.
We'll change the wire, right? You want to change the wire now? Now is the time. The command.
Is that a long one? Yeah. And then we'll treat that with the balloon angioplasty. I'm not going to laser that area or even do anything down distal there, knowing full well that peroneals are only target. And then we'll balloon the the adductor canal SFA, and I think hopefully we'll be done then. Our next case, I'll give you an introduction, is I'm going to do what's known as a PTAP procedure in the next session.
Yeah.
And that's percutaneous bypass. And then, of course, see, that's another addendum to our armamentarium in treating the SFA. So again, your algorithm and how you treat this SFA, whether you'll jump into a FEMPOP above knee, PTFE, vein bypass, where does PTAP fit into this algorithm of treatment of the SFA? Because of these so many options that you have. And I think that's where everybody needs to decide for themselves as to how they're going to treat these lesions in the SFA. Where's the camera?
Hey, Venki, while you're working, we're going to continue with a talk, and we'll watch you on the back end,
go
if that's okay. Steve?
Excellent. Okay, yeah. And then we can then continue the discussion. Okay, thank you so much.
Sounds great.
Good.
It is
Okay,
an
let's go
absolute
down.
pleasure to introduce Steve Hanoi to the stage. CTO. All right, Venki, how are we doing?
Okay, guys. So I think you're doing fine, Adam. So what we did was we used a bigger balloon. We ballooned the proximal after the serenator cutting balloon. The other advantage of serenator, I was told at least, is that once you use the serenator and then a DCB, there's a better chance or a better efficiency of the drug penetrating into the media or whatever it is. So drug delivery through following a cutting balloon may be a little better. Data, we'll have to check on that one. So we ballooned again. Here's the final, and Dr. Loda will play that. That lumen looks much better. We compared that with the especially the distal lesion. That little ulcerative lesion was almost like a 90%. It looks good. And I think, Miguel, and whoever was there, Adam, I think IVUS is really good for these cases here, and I'm remiss for not using it, but that's okay. And then we did the distal. All flow looks good. You go down to the TPT, and you see the TPT into the peroneal looks really good. We used a monorail sublime balloon, and I think all radial approaches, everything has to be rapid exchange monorail. This you may get. And then the very brisk flow down the peroneal going to the foot. And I will give this a shot, and I think she will heal those wounds, which we picked up very early. Yeah, that was the pre. And so I'm going to stop here, and Dr. Loda is going to put in a Zephyr closure device, and you can talk a little bit about how you close radials. But before I leave and go to the next case, I'd like to talk a little bit about what we were talking earlier, is about the transmission of procedures or live cases. Avail was a good streaming platform, and we would do a lot of cases to like 300 people online, and therefore we could reach a much bigger population. So recently, we just got involved with this company called Invisimed, and this is also like Avail, and I think they have a streaming which they may try to show you later on, and then we can compare whether there is, this actual live transmission versus the streaming capabilities, so that you can just pick it up and actually use it in your own ORs to do training courses and stuff. So that's the streaming approach. Yeah, and then you can record all those cases also. Not that you can't record these, but it is a good platform, sometimes even to keep your costs down. Yeah. So I'm going to go. Dr. Loda is going to put in a Zephyr patch here. If you want to go to the next talk, we'll show you the patch later, the radial band, whatever you call that. And then I'm going to go and get the next case ready. And thank you so much, the entire panel. Adam, thanks for showing up early. And so, thank you so much. Take care, guys.
Great job, Venki.